Thank you. Thank you very much, Debbie and Dr. Goldberg. I'm really grateful for the opportunity, and thanks for SAGES to invite me to come and talk to you. First, I'm not a hematologist, and I hope there are not many hematologists here. These are my disclosures. So I'll try to give you a little bit of background on the impact of anemia, and I will cover the hemostasis of iron. I think that's very, very important to understand, and how that impacts on designing a study and designing what to measure and when to measure it, because that's fundamental, and especially on some of the evidence, which I'll share with you, and I'll also share with you some of the gaps. We love guidelines. That's just in Britain, and we've been having guidelines about anemia since 2005, and literally just everything, blood transfusion, anesthesia, surgery, every society, and of course, as you're aware, and NICE guidelines had to support that. And but I'll stop here for, of course, the important one, the international consensus by Munzi in 2017. And they listed actually quite important points in the recommendations about the importance of correcting anemia, when to correct anemia, and how you correct anemia. Do we follow guidelines? Well, we'll discuss that in a minute. And it's not just preoperatively, it's also another one for postoperative. My main area of interest is postoperative anemia, and there are fundamental lack of evidence, I could say, which I'll come to it in a minute. Why anemia is important? Well, I think we've seen evidence that that's an important study here from Musallam et al., and it is a big study, about 250,000 of patients, and looked at the impact of anemia on outcomes. And I think there has been a significant and direct impact of anemia on clinical outcomes, especially mortality, but more importantly is the degree of anemia. That's also essential for patients with comorbidities. In Britain, we looked at similar, but on patients undergoing cardiac surgery, and that's the same. There is a significant, noticeable impact of anemia on clinical outcomes and in mortality. It is proportional to the amount of anemia, and that impact on mortality as well as length of stay. And you've also seen this as well, that iron deficiency anemia associated with high mortality in patients undergoing cardiac surgery, which was also published very recently here in Roessler, by Roessler et al. In Journal of Anesthesia, British Journal of Anesthesia. Why? Why it is like that? Because iron is so important. And I think this is one of the key messages we need to get to the surgeons, that iron is important in all aspects of life. Of course, we're aware about oxygen carrying capacity and storage, which is the 60%, but is an important for energy generation, for key enzymatic process across the whole metabolic process of the body. So it's no wonder why iron depletion is associated with high mortality. Just a couple of points about iron storage. You're aware, I don't need to tell you that, but ferritin is the storage, and the storage is a landmark of anemia. That's why when we talk about anemia and ferritin less than 30, it is the storage level. Also, iron does not travel alone, require transportation, and that's the transferrin. So iron never travels alone, it always with the carrier. And the carrier also, which is the ratio, the TSAT, is an indication and a marker of anemia. So that will make sense later on when we'll start to talk about what are the landmarks what you look for when you're doing blood tests for anemia. It's quite important to understand that there is no specific mechanism of iron excretion in the body. It does not exist. It is all controlled locally, and that is thanks to hepcidin. Hepcidin is created by the liver, and that's what happens is, so we take iron orally, we take about 20 grams, but most of them, they go away, only really 2 get absorbed, and then you get 2 out for discrimination. And then obviously, as I said, I didn't say before, is iron in the natural form is in a ferric state, but it has to be reduced in the intestinal, especially duodenal mucosa, a reductase enzyme to convert into ferrous. Ferrous is useful. That's why the body can use the ferrous. And then it goes, obviously, straight away to the bone marrow, as well as to create the RBCs and the liver. Then you will look for the breakdown, and the breakdown is the macrophages in liver and Kupffer cells in spleen, and that is basically, that's what is the other regulatory process of iron, whether to contribute with this. The key regulation in terms of up and down is by this hepcidin. Hepcidin is basically, it can upregulate or downregulate iron absorption or iron excretion from the cells by the need, basically. So it is sensitized, as I said to you, by the liver, and it does work in that way. Quite an important factor for iron and surgery, it is also important in inflammation. And what do I mean by inflammation? Surgery, basically. So it's really, really important. And you could add to that probably, as you heard, obviously, COVID, and COVID was associated with high ferritin, as you heard about it. It is also interleukin 6, and interleukin 6 is basically what it does is hepcidin is stimulated by interleukin 6 inflammation, and that is actually regardless to the iron level now. So you've got an intermediate factor that it interferes with the process of iron hemostasis, which is all inflammation. And that's quite an interesting graph. It shows you the relationship between ferritin and C-reactive protein. And as I said to you, that's independent to the iron storage. This is an important slide. I always share it with my students to tell them that what is anemia and when is anemia happens. The first one, right at the left, that is when everything is normal. So you've got normal storage, you've got full blood counts, and you've got good transport. Then what happened? You start to lose first the storage. That's really important. And a little bit of the transport. But erythrocytes is okay. There is no anemia. You lose more, and there is no storage at all, the third one. And then you hardly got any transport. But even that, at this stage, the anemia is not detectable because there is erythropoiesis. Then it comes to this one, when you notice anemia. So you could see iron depletion here is, if you just measure it by hemoglobin alone, is a really advanced stage. So that's really, really important. And of course, we'll come to the last one, which is anemia due to functional disorder, functional for iron, which is basically chronic inflammation, which just spoken about. So that's a slide when you want to look and you ask your residents about what to measure and what to measure. These are the standard, basically. Absolute iron deficiency is less than 30, and absolute iron deficiency in the presence of inflammation, these are all the numbers. And functional iron deficiency, it is a ferritin high level. Just remember that it's the opposite to what we think of the normal iron deficiency anemia. Another important slide is the 3 pillars of blood management. We cannot correct anemia with blood transfusion. We must not do that. There are 3 pillars. The first one is optimizing hematopoiesis, and that's really important across preoperative, intraoperative, and postoperative, really fundamental. Now, we're surgeons, we're the one in the middle, is minimize blood loss. That's our function, minimize blood loss before surgery, unnecessarily taking blood, but obviously during the operation and the same after surgery. Third pillar is really important, which is harness and optimize the tolerance of anemia by the patient. And I've just highlighted here one of them is restrictive transfusion. And why is that? Because we know that there are evidence to show that transfusion can be bad. Okay, there are some a little bit of controversy, but there are enough evidence to tell us transfusion is associated with worse outcomes in cancer. Right, so how much do you give iron? As you need basically to calculate, and of course for everything there is a formula, Ganzoni formula. It's based on the body weight plus the target hemoglobin, and when you have a target hemoglobin, you need optimal hemoglobin. It is not like 120, it's usually 150, plus 0.24, and that shows you where it's coming from, plus iron for iron storage. It's not perfect, it doesn't always work, and if I show you here what do you give, and the first study here, they compared oral versus intravenous, and actually didn't show any difference because of the dose. Is the dose dependent? And if I give you a key how much you give, minimum 1 gram of iron intravenous, and you need 4 weeks. So 4 weeks is the key factor. And we don't like to give smaller doses repeated. So you would rather give a large dose 4 weeks before surgery, you get the optimum. 2 weeks, which is a problem with a big study, as I'll share with you in a second. Adverse effects, to be honest, it is a safe drug, but anaphylaxis and allergy and some sort of flu-like symptoms can be obviously noticed with that one. So a couple of the studies with the anemia. Basically, this is a study by Brent Frossler, and it is a shame that this study closed early because they actually noticed significant difference with the usual care in negative outcomes compared to the intervention, which is a correction of anemia. So that is stopped early. The second one is IVICA study. That was a British study, randomized controlled trial. It didn't show any difference in blood transfusion requirement, but it showed improvement in basically iron level, more effective in intravenous than oral. There has been some systematic reviews at that stage, and these systematic reviews showed better, obviously, outcome with iron correction, iron replacement. But until that stage, obviously, we did not see this study, PREVENT trial. PREVENT trial, Toby Richards, is published very recently, I think just over a year now, and that showed something different, that correction of iron actually, preoperative intravenous iron was not superior to placebo. So it's like a shock. You're saying, well, hang on a second, what's going on here? After all of this, and now there is a big randomized controlled trial published in Lancet, and it does not show any difference between preoperative intravenous iron versus placebo. Why is that? Well, let's look at that here. Well, there are a couple of issues with that, which I'll come to them in a minute. But if you notice here that readmission to the hospital following surgery was significantly lower in the intravenous iron group. Why? Because they gave the iron too short, within 2 weeks from surgery. And that goes back to, again, to that diagram with the iron repletion. And again, it's purely based on anemia. So they waited for drop in hemoglobin, which was a later stage. So that's why I had to give you that headache and show you all of these homeostasis of iron. So a standard dose of iron to every patient, regardless to their severity of anemia, and there was heterogeneous recruitment of patient cohort. So there are actually some gaps in this study. Probably one of the best systematic review by my colleague Richard Orma. It just basically, you're saying that correction of anemia, it works, but you need to do it in the right way, basically. So I'll finish with a couple of slides of my studies, which I've done about perioperative anemia, looking at preoperative and postoperative anemia, 500 patients, find 40% were anemic preoperatively, but my surprise, 70% was, over 70% were anemic at discharge, and sadly I didn't know that. I would only know that after they've gone home. Conversion, of course, was associated with anemia at discharge. What's important is we noted that difference with preoperative anemia, which is not a new one, in survival, 5-year survival. But what surprised me is the postoperative anemia. There was a significant difference in survival between a patient went home anemic versus one. That is, when we did that, we standardized for a stage. So that's not the ones they high stage and higher anemic. No, we standardized. We did a cross-matched per cancer stage. They were independent to their cancer stage. They were still lived shorter. So we did a systematic review. There were hardly any studies. There were only 6 studies. One of them is mine, and I don't want to give you a headache. What can I tell you at the end? I think preoperative anemia is hardly prevalent, is really associated with worse outcome. That's probably one of the key messages you take here. Iron is essential for life. Understanding iron hemostasis, I think, is important if you want to design a study, and I think you want to measure what is the right outcome, what to give, and when to give. That is probably explain why we're having conflicting results from all of these major studies, and correction of preoperative anemia associated with increased preoperative hemoglobin. There are still fundamental lack of data on postoperative and functional outcomes and impact on perioperative care. And at the moment, we are running a quality improvement project to enhance the perioperative anemia and measure why we're not sticking to it. I'd like to thank all of the people who contributed, and I'd like to thank you again for this opportunity. Thank you.